Dear audience, I would like to present the topic of my PhD thesis, which is the investigation of the link between different diseases from the aspect of the oral microbiome. My name is Zsuzsanna Domokos from the Department of Community Dentistry. My vision is to develop interdisciplinary knowledge by investigating the association between dental and systematic diseases and also improve the treatment, which improves both dentists and medical doctors. My mission is to incorporate multidisciplinary attitude into clinical practice based on a comprehensive knowledge. My specific goals in order to fulfill my mission and vision is try to identify a risk population in dentistry and also improve the treatment and the follow-up method of periodontal patients. The title of my first project, the title of the manuscript is Patients with Inflammatory Bowel Disease Have a Higher Chance of Developing Periodontitis, which is a systematic review and meta-analysis. According to different epidemiological studies, periodontitis is one of the most common oral conditions in the world. It can affect from 20 to 50% of the adult population. However, severe periodontal disease can affect 10% of the adult population, which is one of the major causes for tooth loss. Moreover, it is not only an oral condition, but it can cause also coronary heart disease, preterm birth, or even stroke, which can even cause the death of the patients. It is known that there are several risk factors for developing periodontitis. Some of the most known are poor oral hygiene and smoking, but it is also known that there are systematic diseases like diabetes mellitus and hematologic disorders which can contribute into the developing of periodontitis. And their question was that if maybe IBD can also contribute to developing periodontitis, but also the other way around, this association might be true. As both diseases are multifactorial, investigating the possible association between them could improve the interdisciplinary knowledge about these diseases and also improve the treatment. The aim of our study is to investigate the association between periodontitis and IBD from both directions and try to identify a possible risk population and also some common risk factors. Our clinical question was the following, which you can see on the slide. We used two PICOs, as I have said, to investigate the association from both directions. Our hypothesis was that IBD and periodontitis are associated, and the clinical implication of the study was to identify a risk population. Here is the systematic search. The search was conducted in October with the following search key in the three main big databases. Here's the flowchart of selection, and after the selection process, we had 14 eligible articles. As a primary outcome, we compared the odds of periodontitis in IBD patients and in non-IBD patients. So we got odds ratio results on the first data. So here we measured the odds ratio in IBD and in non-IBD group. The odds ratio was 2.65, which means that patients with IBD has 2.65 times higher chance of developing periodontitis than patients without IBD. The heterogeneity of this evaluation was 0%. We also did this evaluation separately for Crohn's disease and ulcerative colitis group, which you can see on the following slide. On the case of only Crohn's disease patients, the odds ratio was 2.22. And in the case of ulcerative colitis patients compared to healthy population, the odds ratio was the highest from the three cases, but this was 3.52. But this means that in all three cases, the odds for developing periodontitis in the investigated group is higher than in the healthy population. As secondary outcomes, we investigated the different clinical periodontal outcomes. We compared the numbers in the IBD group and in the healthy population. But unfortunately, in the literature that was available, most of the studies used not standardized way to measure the clinical periodontal outcomes, so only a few studies were available. However, these results showed a statistically significant difference between the clinical periodontal outcomes. However, in the clinics, they are not very important. As a summary, the main strengths of our study is that we investigated a clinically relevant question. We used only high-quality studies based on the Newcastle-Ottawa scale, which we use for risk of bias assessment. To our best knowledge, this is the first study to investigate the association between IBD and periodontitis from both directions, and we followed a very rigorous methodology throughout the whole process. As a limitation, I would like to mention that we investigated also it from the other direction, as the second PECO or PECO-B, but we found only 2 eligible studies which investigated this direction, so these studies could only be part of the systematic review. And as I have mentioned, the measurements, the periodontal measurements, were usually not done in a standardized way, so we should emphasize that we should always use a standardized way, so these results can be compared in the future in a meta-analysis. The biggest conclusion is that IBD patients have a higher chance of developing periodontitis than IBD-free patients. As an implication for practice, we should mention that a multidisciplinary attitude should be brought into the treatment of IBD patients. Both gastroenterologists and dentists should be aware of this association, and the gastroenterologist should emphasize the importance of the regular dental checkups and prevention in IBD cases even more than in the healthy population. As an implication for research, we know that both diseases are multifactorial and their complete pathogenesis is not fully understood, so investigating this association between them, we might find some common immunological or genetical pathways or also some common behavioral environmental risk factors. We finished the submission in August and we submitted our manuscript into the Frontiers in Medicine Q1 journal. The title of our second topic is the association between matrix metalloproteinase 8 and clinical parameters in periodontitis, which is also a systematic review and meta-analysis. Periodontal diseases are destructive processes involving the periodontium, which is the supporting apparatus of the tooth. On the following slides, you can see the picture and the clinical parameters, in this case of a healthy patient with healthy periodontium. In this case, you can see a patient with gingivitis. In this case, we experience bleeding on probing. However, there is no attachment loss. Compared to this, in the case of periodontitis, we can experience both radiological and clinical attachment loss in the patient. In the histological case of the healthy gingiva, we cannot experience inflammatory cell infiltrates, and we can see straight gingival cells. However, only after 4 days of some attack, maybe not brushing your teeth properly for 4 days, some leukocytes appear and the collagenesis happens. In this case, the matrix metalloproteinase, which is this enzyme, elevates, but the signs of the clinical disease can be experienced only later, in a later phase. The MMP8 is a collagenelytic enzyme. It causes periodontal degeneration, and in active periodontal diseases, we can see the pathological elevation and activation of MMP8 in periodontal tissues, and we can measure it from the gingival sulcus or from the saliva. The aim of our study is to compare how the level of MMP8 changes in periodontally healthy patients and in patients with periodontitis. We will compare the reliability of MMP8 level measurement with conventional clinical and radiological diagnosis. You can see the clinical question, which was the following: is measuring the level of MMP8 a reliable method to diagnose periodontitis? Is it an appropriate tool for long-term follow-up of periodontal patients? We will use the following PECO. Our main outcome was to measure the MMP8 levels, and as additional outcomes, we will measure the correlation between MMP8 level and clinical periodontal outcomes. The clinical implication of our study is to use a novel, simple, and convenient method to diagnose and follow up the clinical stage of periodontitis. Here is the following search key which we will use. Right now, we are at the phase of the data extraction, but now we are waiting for some statistical consultation to go on with the process. We will also do a subgroup analysis, as you can see on this slide, based on the types of periodontal disease. We will separately investigate gingivitis and periodontitis case, and also we will make subgroups based on the device used to measure the MMP8 level measurements. So I would like to thank you for your attention with this quote. Every mountaintop is within reach if you just keep climbing.
Thank you. And now it's time for questions.
Do you know any under investigation processes that can help on IBD patients' periodontitis?
Thank you for your question. Also, there was a previous meta-analysis previously, so it used only studies that so in the past. So we could apply more studies into this meta-analysis. But also, in that case, in the past, it also showed a possible association between these two diseases. So there were other studies which, for example, investigated the microbiological association between them, or the immunological association between them, or also some of the genetical association between them. So there are different ways, different aspects as we can investigate it from different directions. Thank you.
So technically my question was, is there any treatment to this problem to prevent periodontitis?
Yes, there is a way to prevent periodontitis, but it is not true only for IBD cases. It is true for every case that the perfect oral hygiene method can prevent the periodontitis, because as I have mentioned, the biggest risk factor for periodontitis is poor oral hygiene. So we say that if there is no plaque, even there is genetic predisposition or other systematic diseases, the periodontitis cannot show.
I'm not sure, but I have some old memories. Isn't there any MMP8 chair-side diagnostic tool in periodontitis diagnostics?
Yes, thank you for the question. There are two big groups that we can measure the MMP8 level with. There are chair-side techniques and laboratory techniques. So in our meta-analysis, we will make subgroups based on, because it's not possible to compare the chair-side technique and also the laboratory technique, because we get very, very different results.
Okay, so I'm really interested in your conclusions, because I think the chair-side diagnostics, it's a developing field in dentistry. Thank you.
Thank you for the nice presentation. My question is about the first project as well. Is there any correlation or higher frequency of periodontal disease in patients with more severe IBD or a certain type of IBD, or any kind of correlation like this? Should we expect of something?
There are only a few studies, but most of the researchers try to investigate this aspect also. Most of the studies found no association between the severity of the disease or the treatment used for IBD, but maybe all of them concluded that this might be because of the low number of patients investigated.
I would just confirm that you are not setting a correlation, a causative correlation between IBD and periodontal disease. There is
no.
You did not have a conclusion like that, right?
No, because no
okay.
RCTs are possible to investigate this association. So we see a positive association, but this does not prove that they are cause related.
Correct. Thank you.